Welcome to the Introduction to the Cardiovascular System Learning Program. My name is Trish Enright, and I will be your host for this WebEx. I too am a nurse, and I have over 20 years experience in the healthcare industry, and I have been responsible for product positioning and training, and I'm really thrilled that you can all attend our very first online continuing education course for case managers. So A.D.A.M, if you're not familiar with A.D.A.M, we offer these learning programs, and they are available on our website. Our website is www.adam.com, and this particular CE program will be available for you all for the next 30 days. So at the end of this program, you will have a link to this CE, and you will also receive a link to take the final test or the final assessment, where you will be awarded 1 contact hour credit and you will receive a certificate. For those of you who may be unfamiliar with A.D.A.M, you may be wondering what A.D.A.M stands for. A.D.A.M is the animated dissection of the anatomy for medicine. We are the largest animation library in the world. Our award-winning medical library of content can be easily integrated into any website. We are the pioneer for medical education programs and one of the largest and most comprehensive image and animation libraries in the world. For some of you older nurses out there, you may remember in nursing school looking at all of the illustrations and animations when we were learning our anatomy and physiology. Well, that was all A.D.A.M. Our highly detailed medical accurate images and illustrations include disease states, injuries, tests, treatments, surgical procedures, and human anatomy. And the most prestigious institutions utilize A.D.A.M's content. These include the National Library of Medicine, the National Library of Health, Walgreens, Google, Bing, University of Maryland, University of California, and thousands of health plans and hospitals and hospital systems across the country. So what we're going to be doing today is taking you through this module, Introduction to the Cardiovascular System, and we will also provide a link at the end where you could go back after this time and view the module in its entirety. All of our modules are self-paced and narrated, so it makes it very easy to obtain your CEs. Are there any questions so far? Of course, we have to put the disclaimer in here, and this is specifically for our lawyers. We are a division of EVICS, and we are committed to providing the highest quality of care education possible. And every effort has been made to provide you learners with the most accurate, complete, and up-to-date information. So what we wanted to do first is to go through the cardiovascular system and let you know a little bit more about this. This program is designed to introduce you to the main features of the cardiovascular system and how they work together to carry out important functions of the body. The program is going to begin with an overview, followed by an explanation of the components and functions. And here you will learn the different components of the heart and homeostasis. You'll also learn the structures of the heart, the cardiac cycle. You'll learn about the conduction system and ways that you could help decrease cardiac readmissions. You're also going to see some quizzes that will pop up throughout the presentation. And these are just basically progress checks. But you don't need to worry about these. We're going to use a poll and see how people answer it, generally speaking. But note that some of these quizzes will also be the same questions on the final exam. So today what we're going to cover are these learning objectives. We're going to identify the components of the blood, explain the functions, identify the components of the heart, explain the functions of the heart, explain the function of blood vessels, and ways to articulate decreasing readmissions, cardiac readmissions. So without further ado, I'd like to introduce our guest speaker and medical advisor, Dr. John Borowski. He is a board-certified family physician with broad experience in hospital and clinic-based medical care. He is a graduate of the University of Melbourne Medical School and completed a graduate diploma in family practice at the Hebrew University of Jerusalem. He also has a master's degree in public health at the University of London. In addition to his clinical work, Dr. Borowski has worked in the HMO management and healthcare policy research areas, and he has also served as a military physician for many years. He also holds the rank of major. Dr. Borowski has been heavily involved in the training of family physicians, interns, medical students, and lectures widely to professional lay audiences. Since joining A.D.A.M in 2011, he has been a key person involved with our narrative-based e-learning programs. Please help me welcome Dr. John Borowski.
Thank you very much for that, Trish, and welcome to everybody on the line. It's a pleasure to be here. Essentially, what we're doing in this webinar is using a medical education program which can also be used in a self-directed fashion. So if we don't manage to get through all the content in the 50 minutes that we have left, you can always go back in for the next 30 days into this program via the links that you'll be given and complete any stuff that we don't manage to get through. And essentially what we're doing is going back to the basics of the cardiovascular system, which is a good thing to do every once in a while. And what I'm going to try and do is to show you how this kind of refreshing of the basic anatomy and physiology can kind of give you a little bit more insight into readmissions, and specifically to readmissions for heart failure. So maybe just before we get into the actual cardiovascular system, I'll just mention why that's such an important thing. As you probably know, heart failure is, the leading cause of hospitalization among elderly adults. I think just Medicare expenditure alone in the US is beyond $17 billion. And we can see how difficult it is to manage chronic heart failure because of the number of hospitalizations every year in the US. And also we see that these hospitalizations are kind of don't manage to really fix the problem in a significant way. And this is proven by the fact that 27% rather of patients after they're discharged are going to be readmitted within 30 days. This is the highest readmission rate that exists for any disease category, including chronic obstructive pulmonary disease, pneumonia, psychosis, and psychiatric disorders, and even for major surgeries. Now, I suppose the most important thing about heart failure readmissions is that we believe that about 25 to 40% of them are avoidable. And when we look at the best practices in hospitals, at least in the United States, we know that about a 30-day readmission rate of 17% is pretty much what best practice is at the moment. So, in other words, we can really save at least 10% of these readmissions with current best practices, and probably much more if we deepen our understanding of the cardiovascular system. So we'll just move right along. So I think it's really important to know that the human body is very large, very complex, and the cells can't just receive oxygen from the outside environment or the nutrients. We've got an elaborate system to deliver oxygen and nutrients to the cells on the surface of the body and deep within the core of the body. Essentially, this delivery system is the cardiovascular system. As lying in the center of this system, as it is in the center of the slide, is the heart. And that's a pump. It's the body's main pump. In 1 minute, it can move 5 liters of blood through each ventricle. Can move 14,000 liters or 3,600 gallons in a day. And the closed-circuit vascular system that we have, if we lined up all of those blood vessels end to end, we get about 100,000 kilometers of blood vessels, which is a quarter of the way from the Earth to the Moon, which is fairly amazing. And some of these vessels may be familiar to you. the large arteries and veins, the aorta, the largest artery in the body, the carotid artery supplying the blood to the brain, and the vena cava, which is the largest vein in the body. You keep moving through.
So these are some of the pop quizzes that I mentioned earlier. And again, this is all self-narrated. So at the end of the session, you could go back and look at this. So if you have a moment and can look at the question here about how many liters of blood does the heart move through each ventricle in 1 minute? Please answer the question either 1 liter, 5 liter, 10 liters, or 40 liters. Please answer now. Oh, time is up. Well, if you said 5 liters, you would be correct. 5 liters is how much blood is transferred within 1 minute. Okay. John, the next section, please.
Thanks, Trish. So, getting back to basics. So, if we try and split the cardiovascular system up into its 3 main parts, we've got the heart, we've got the heart vessels, and we've got the blood. The heart is obviously the pump that ensures the circulation of the blood. The blood vessels are the conduits which transport the blood throughout the body to where it needs to get to. Just to refresh you, arteries are the big vessels carrying blood away from the heart, and veins that carry blood towards the heart. And due to the pumping action of the heart, the blood travels through these vessels under pressure. You know what we know as the blood pressure, and that varies with the distance between the distance from the heart of each particular artery. Obviously, in addition to the fact that the blood vessels form a structural conduit, they also play a role in through factors that they release from their linings to maintain homeostasis. Now, when we get towards the end of the arteries, we reach capillaries, which are microscopic vessels found near almost every cell of the body. And they are the site where nutrient exchange happens, which is one of the most important functions of the cardiovascular system. The blood passes back from these capillaries into the veins. It's now, the pressure's now dropped considerably, as has the amount of oxygen in the blood. And that's why we think of veins as being blue, whereas arteries, which have blood which is rich in oxygen, is red. And in order to get that blood back to the heart, despite the lower pressure, the veins also have some valves in them, and we use some muscles in our body to get the blood back to the heart. At any given time at rest, about 65% of our blood is in the veins and venules, compared to 13%, which is in the arteries, and the remainder is in the capillaries. And obviously the pulmonary blood vessels and the heart also has 7% of the blood in it.
Okay, we have another pop-up quiz coming. Are you all ready? At rest, where is most of the blood located in the body? Well, if you said systemic veins and venules, you would be correct. At rest, as Dr. Borowski said, 64% of the blood in the body is systemic veins and venules, compared with 13% in the systemic arteries and arterioles. The remainder is found in the systemic capillaries and blood vessels in the heart. And then this is just the section summary, talking about what we just went through, and this is also included in each of our modules. And again, the CE modules can be found at www.A.D.A.M.com. And now we're going to go through the blood function.
Thanks a lot for that, Trish. So just as by way of introduction, as I suppose most of you know, the blood is a complex mixture of liquids and of what we call formed elements or cells of the blood. And it has a variety of functions. It's one of the most fascinating parts of our body. It's a transporter. It regulates our body temperature and pH, and it also protects our body from injury and from the onslaught by microorganisms. And just in the next few slides, we'll learn about all the various components of the blood and the functions, just in a fairly brief way. Just moving along. Yeah, so basically what we're trying to show here on this slide, that if we spin down blood in a centrifuge, it'll split up into what's called the formed elements, or the cells, and into the plasma. The plasma is lighter. It's essentially fluid, and it contains proteins, antibodies. It contains the oxygen and carbon dioxide, mostly the carbon dioxide, because the oxygen tends to be linked to the red blood cells. But there is oxygen also just dissolved in the plasma. There's enzymes and hormones and electrolytes and nutrients and waste products that are also all being found in the plasma. And obviously the three main types of blood cells are red blood cells, white blood cells, and platelets. Red blood cells, main job, carrying oxygen. The white blood cells are the most important part of our immune system. You don't live very long if you haven't got any. And platelets are an essential part of the clotting mechanism, whereby if we're injured, we don't just bleed and bleed and bleed without stopping. Thanks. Yeah. So the blood function. Oh, sorry. No, we can go back just a little bit. Yeah. So basically, the blood's main function is to transport the oxygen to every part of the body, and to transport out carbon dioxide waste products, which will then breathe off into the atmosphere in the lungs. It's also delivering all of our nutrients, specifically glucose, sugars, and hormones. It's the medium by which hormones spin around the body. Hormones like insulin or thyroid hormone. And these are all important, very, very important. The other major job of the blood is to transport proteins and immune cells, which are going to protect our body from infection and disease. And obviously blood clots, so that when we're injured, it's the first line of defense between losing all of our blood and other fluids if the cardiovascular system is damaged.
Okay, so now it's time for another test. And again, these quizzes are cumulative, so at the end will be a final exam. So please note what the questions and answers are. Blood transports A, carbon dioxide from the lungs to the cells of the body. It carries oxygen from the cells to the lungs. It also regulates pH in tissues, blood and immune cells, and proteins contained within it. Protects the body from infection and disease.
Oh, not to worry, Trish. It's okay. I think you just flipped the carbon dioxide and oxygen back to front, but that's okay.
Sorry.
We won't hold it against you. It's all good. We'll just keep, Trish. Let's just keep moving through this progress check.
Yep.
That would be great if it lets us. Is it going to give us a hard time?
Let me do that.
Yeah. So maybe I'll try answering this one, if you like. So the proteins, the blood components involved in maintaining osmosis are the proteins. If you can select that, and then the program will let us continue on. The plasma proteins, it's the fourth option. And obviously the white blood cells are the cells that we spoke about being involved in immunity. The red blood cells are the main transporters of oxygen, although, as I said, there is some oxygen dissolved in the plasma. And the platelets are what help us prevent too much bleeding when we're injured. Right. Oh, amazing. I had some inside information, I'll admit it. So just very, very quickly about hemostasis. So what happens when we actually get cut or our finger is pricked? We do bleed, but we actually manage to stop that bleeding fairly fast. The first step is the spasm of the vessels through which the blood is flowing, which reduces the blood flow to the damaged area. And then what happens is we form a platelet plug, and then there's a cascade of a number of different proteins in the blood, which stabilizes that platelet plug and make sure that it doesn't get stuck. Why don't we go ahead and click that slideshow icon so that we can see that it's happening as a slideshow. So here we can see the injured vessels. The vessel has constricted. The platelets gather at the site of injury and stick to the wall of the vessel and also stick to each other. They're releasing then factors which are going to draw which are going to cause a cascade which essentially creates fibrin. And fibrin is a insoluble fiber that essentially sticks to the platelets and stabilizes that.
So while we're waiting for John to get back on the line, this is Trish Enright again. I'm your host for this CE, and this is our very first online CE, so we appreciate everybody's time. As I mentioned earlier, all of our CEs can be found at www.A.D.A.M.com. We have gotten several of our CEs now certified, and they are all self-directed and narrated. And for a period of 30 days, you can log on. We'll give you the link, and you can view this CE at any time that you'd like or share it with your colleagues and receive 1 contact hour credit. Also, John is calling in from Israel, so he's calling from far, far away. As I mentioned in the introduction, he is a military doctor, so he has been stationed in Israel for the past couple months. So hopefully he'll be able to connect here soon. I'm just going to go ahead and go through this slide here regarding the blood. In response to abnormal... Okay, well, you know what? I'll just continue on, and we'll hopefully be able to connect back with John here soon. So basically, erythropoiesis, this is a response to low levels of oxygen in the blood, and the kidneys release this growth hormone, erythropoietin, in the blood. And this acts as a precursor cells to the red bone marrow, and this is at the site of all blood cell production. It stimulates the red blood cells, and this process continues throughout until all red blood cells have been produced to raise blood oxygen levels. So here again we have our next quiz, and go ahead and see if you can answer these steps. Basically what we want to do is put the steps in order. So think through what it might be. The first one would be step 1, a cascade of chemical reactions produces fibrin. Nope, that's not the answer. It would be number 4. So 1 is the blood vessel is damaged. So that would be the first thing that happens. The second thing that would happen is a vascular spasm begins to reduce blood flow to the area. The third step would be a platelet plug begins to form. The fourth step would be the blood would be a cascade of chemical reactions, and then a mass over the wounded area traps circulating blood cells, including platelets. And that is the correct answer.
Good job, Trishka. Am I back online now?
Yes, we can hear you. Great.
Oh,
great
wonderful.
Yeah. I hope
So
there aren't
sorry
any
about that.
bombs or anything going on, John.
No, it's all good. It's all quiet and peaceful over here now. Thank goodness.
Good.
We're all good. Okay, so let's move right along to the heart. Fantastic. Thank you very much for keeping it moving, Trish. I apologize for that, and apologize to everybody that's with us. Not quite sure why we dropped out there, but in any case, so we're just before we start talking about the heart itself, I wanted to just mention a new concept in predicting cardiac failure readmissions, which are very, very relevant to the heart's structure and its function, particularly the filling of the various ventricles as the blood moves through the heart. So recently there's been a number of studies in the medical literature about ventricular filling pressures, which their rise over a number of days or weeks is a very good very good predictor of somebody that's about to go into decompensated heart failure and need readmission, going to get short of breath and not be able to function. And we can actually monitor these ventricular filling pressure rises using non-invasive techniques now. For example, Doppler echocardiography, which is essentially an ultrasound of a method of ultrasound of the heart. And I suppose why this is important is because if we can see what's actually going on in the heart itself in terms of the physiology of the heart, and that gives us a warning sign that the heart is going to begin decompensating, we can identify those patients who are really going to benefit from some extra intensive therapy or for a review by a cardiologist, and we can maybe make some changes before we really get into that severely decompensated stage that requires readmission. So just to give us a quick overview of the heart, it's a very small organ. It's about the size of a closed fist. It's a pump, essentially. On its surface, it has its own blood supply because obviously the blood can't get to all the different cells of the strong heart muscle without going through arteries, arterioles, and capillaries. There's three layers to the heart: the epicardium, the myocardium, and the endocardium. The myocardium is the important layer. That's where all the muscle is. And there's also a fairly strong sac that encloses the entire heart, which is called the pericardium. We can move on. Okay, great. So now we're looking at a slice through the heart, really to try and identify the four chambers of the heart. You can see the two upper chambers in a kind of purplish color on the left and right-hand side. They're the right atrium and the left atrium. We're looking at the heart as if the patient is lying on the bed, and we kind of cut the chest open and open it up like a refrigerator, let's say, and then we're looking into this cross-section of the heart. Those upper atria receive the blood from the veins and then that blood flows through valves into the ventricles, which then pump it back out into the arteries. The right side of the heart and the left side of the heart are separated. The right side pumping the heart from the systemic veins into the pulmonary arteries and towards the lungs, whereas the left side of the heart, which has, as you can see, has kind of thicker muscle, it's stronger, it's more powerful, and that pumps blood. It receives the oxygenated blood back from the lungs via the left atrium into the left ventricle, and then gives a big strong squeeze and pumps it out into the rest of the body. We can keep moving. So now it's more as if we'd like, if we were opening a cookie jar if we were kind of looking down on the heart from above, we were flying over the heart with a person standing up, and we're looking down upon it in order to look at the valve. And what we see is that there's four valves, essentially. One valve each between each atrium and ventricle, and another valve between each ventricle and the arteries leading either towards the lungs, in the case of the right heart and the pulmonary circulation, or towards the rest of the body, when we're talking about the left heart. And you'll notice about the valve that 3 out of 4 valves have 3 cusps, and 1 out of the 4 valves, the mitral valve, only has 2 cusps. The ones with the valves between the atria and the ventricle are called the atrioventricular valves, obviously, and the ones that lead outwards are the semilunar valves. And, I mean, a valve is essentially the same thing that it is in any system of pipes. It enables the flow of the fluid in only one direction. We can keep going.
Okay, so we have another progress check here. So the right side of the heart supplies the cardiac, hepatic, or pulmonary. Are we doing a poll, or are we not doing a poll, Jen? No?
I don't believe I have a poll for this one.
Okay. It's pulmonary circulation, while the left side supplies the systemic circulation.
And
Okay, and now we're going to go through the cardiac cycle.
Okay, fantastic. So, so basically, the heart contracts in a very coordinated fashion, and if it's not contracting in a coordinated way, then we're not going to get the optimal movement of the blood through the pump. One beat of the heart is called a cardiac cycle, and it involves a sequential contraction and relaxation of the atrium and the ventricles. And what's happening when the contraction happens is we get changes in pressure, and those pressure changes move the blood from one part of the heart to another part or out of the heart. And as I said before, the pressure, if we have an increased pressure, if we require increased pressure specifically on the left side of the heart, which is the side of the heart that needs to work the hardest and get the blood to the whole rest of the body, if the pressure that the heart has to work under is increasing and increasing and increasing, then that is a warning sign that the heart may then be in imminent failure. And I suppose that's fairly, an intuitive sort of thing, that if you make somebody work harder and harder and harder and you crack the whip, eventually he's going to break, and eventually he's just going to run out of steam. We can show the cardiac cycle. Maybe just go back, Trish, just so we can show the cardiac cycle using that animation, using the animation icon. Just below, yeah.
I think there might be a little bit of a delay.
Yeah.
There we go.
Oh, that's okay. So I mean, this is basically just showing you how the blood, when the heart contracts rhythmically, first the blood fills from the atria to the ventricles under its own steam, and then it gets a little bit of a contraction of the atria to finish the filling of the ventricles, and then in a coordinated fashion, the ventricles then contract, and that increases the blood pressure to a higher level than it is in the arteries leading away from the heart, whether they're leading towards the lungs or towards the rest of the body, if it's on the left-hand side rather, and that's basically the way in which the pressures change and the blood moves. We can move along now, Fish. That's fine. I think we get the point.
And this will be a very important section because this is also on the final exam. Place the stages of the cardiac cycle in the correct order. Assume we begin the cycle just after the ventricles have already maximally contracted. So the first step would be the ventricles relax, pulling blood into them from the atria. The second step would be the muscles around the atria contract, pushing blood from the atria to the ventricles. The third step would be the ventricles contract, increasing the pressure of the blood inside. And then the fourth step would be the semilunar valve is pushed open and blood rushes into the aorta.
Trish, you're getting good at this.
I'm telling you. Theory.
Okay, that's great. So obviously the next step, if we're leaving the heart now, is we have the pump that we understand that. Now we kind of need to talk about the pipes. And as you can see in this diagram, the piping system is fairly simple, but not entirely simple. So let's start with the pulmonary circulation, which in a way is kind of a little bit easier to understand. As you can see from the heart, the right heart takes blood that looks blue because it doesn't have oxygen into it, sends it towards the lungs, where the blood picks up the oxygen and gets a more reddish color, and then comes back towards the left atrium and ventricle. And then the systemic circulation, which is red, oxygenated blood goes out through the aorta and into the various arteries that make up the body. There's one caveat in terms of, and then it goes into capillary beds in all the different organs, whether it's in your muscles or in your solid organs, to your brain, to your lungs, to your brain, to your kidneys, to your large muscles. There is one area of the body, though, that actually the blood needs to go through two different capillary beds in order to get back to the heart. and that's what we call the portal circulation. Now, what happens is the blood passes through the capillary beds around the bowel, particularly the small bowel, and there it picks up all the nutrients that get absorbed from the food that we've eaten. But because those nutrients need to be processed, and also the blood can pick up there a bunch of poisons that can do us damage, before coming back to and joining the rest of the circulation, it needs to go through the liver. And that vein essentially leading from the bowel to the liver is called the portal vein. The liver, interestingly enough, actually has its own arterial blood supply as well. So it kind of has a double blood supply, the liver, which is, if you think about it, makes sense. Often people talk about, people were in a car accident and they had a laceration of the liver and they bled to death. The liver is extremely rich in blood, extremely difficult to operate on in terms of controlling the blood flow, and extremely vulnerable to injury in terms of the amount that it can bleed. But let's keep going. Now, the kidney is very important, and it directly relates to heart failure as well, because the kidney is probably one of the most fragile organs in terms of the blood supply that it needs. When it's not getting enough blood supply, it can't make enough urine. We end up retaining fluid and water, and heart failure can really, really spiral out of control. Essentially, the kidney, if we think about it, is just a very, very fancy form of capillary, a very, very fancy form of blood vessel, which enables us to filter the waste. Afferent arterioles bring blood from the systemic circulation into the glomerulus, which is essentially a very specialized form of capillary, and then venules lead this blood back out of the glomerulus, and in between the glomerulus and the Bowman's capsule, that's where basically all the filtration processes of the kidney are taking place. Let's keep moving.
Okay, so we have another quiz coming up. In which of the following paths of circulation does the blood always flow through two capillary beds before returning to the heart? Coronary circulation, hepatic, pulmonary circulation, or the circulation of the head? Well, if you said the hepatic portal circulation, you would be correct. We'll need to speed it up just a little bit.
Yeah, I'll do my best. Thanks, Trish. So just very, very briefly, we'll go through the coronary circulation is critical. It's everybody knows what having a coronary is. The blood vessels that lead the blood through the heart muscle get blocked. The muscle dies. We get scar tissue. We get a number of different complications. We can have rhythm disturbances, and essentially the pump stops pumping well. So coronary arteries are very, very important, as are the coronary veins, although the main problems we have are with the arteries. Let's keep moving. This is fairly self-explanatory. We can move through that. Essentially, the only point is that while the heart is contracting, the coronary arteries don't have enough pressure, don't have high enough pressures within them to overcome the contraction of the heart, and therefore, through every beat of the heart is getting a certain period of time where the oxygen's not going to the heart muscles. So this also in heart failure, we can understand that if our heart starts beating too fast, if sometimes people over-exercise or whatever it might be, and the heart rate speeds up, then the amount of time that the blood cannot flow through the coronary arteries simply because the heart muscle is contracted gets worse, less oxygen gets delivered, and you can have decompensation of the heart failure. Major coronary veins are very interesting anatomically, but probably a little esoteric for our needs today. They basically drain directly back into the heart in a fairly sophisticated fashion via the coronary sinus, which is a very, very large vein on the posterior surface of the heart. Here it's as if we're looking at the heart through the back from behind, and we can see the coronary sinus, which actually doesn't lead into the vena cava, but actually leads directly back into the heart itself, which is fascinating from an evolutionary point of view, but probably beyond what we need to what we need to deal with today. So I'll just, before we get into the conduction system, I suppose the question is, how does the conduction system relate also to heart failure and to readmissions? We don't necessarily think of we think of kind of heart arrhythmias, heart rhythms as something that kind of makes you drop dead, and the paramedics come and they defibrillate your chest, and the patients, they get a big, strong electric shock, and we're not quite sure how that has to do with, and we don't necessarily relate that with heart failure, especially not with readmissions. But actually, one of the most common reasons for readmission for patients with heart failure are cardiac arrhythmias, are disturbed heart rhythms. They account for about 13% of readmissions, and another 15% if we consider the side effects of the drugs that we put people on in order to prevent the arrhythmias. So we're talking about 28% of readmissions being caused either by arrhythmias or by their treatment. So it's very, very important that we understand how the cardiac rhythm might impede the proper contraction, and therefore the strength of the cardiac pump. And because when that strength fails, then people get readmitted. Just as a side note, the other main causes for acute decompensation, what we consider an exacerbation of heart failure and a need for readmission. One of the most important ones, which accounts for about 22%, is a lack of adherence to salt and water restriction. My clinic, actually, when I work out of Israel, is next to the main market, and we often get tourists coming through the market enjoying sampling the variety of olives and pickles, pickled eggplant, and all different stuff like that. And then they wind up in the emergency department with an exacerbation of their heart failure because they've failed to comply with adhere to their salt and water restriction. Very, very, very common thing when we see tourists. We say, oh, you just came from the market, didn't you? Other than that, infections and kind of non-cardiac causes cause a lot of the acute decompensation, about 20%. And medication adjustments account for a further 15%. So they're the main reasons why people might present with an acute decompensation, and what we would consider probably a preventable admission for heart failure. All right. So when we're looking at the conduction system on the screen, sorry, we'll do the conduction system real fast. Trish, if you can go back, thanks. So essentially, all the fibers in the heart are autorhythmic. It means they can all beat, essentially. The beats start at the sinoatrial node, which is in the upper part of the right atrium. That's the part of the heart. That's the pacemaker of the heart. It beats fastest. And basically, once the pacemaker beats, the rest of the heart wants to beat. It goes down to the atrioventricular node, which sits at the junction of the two atria and the ventricles. And then it travels along what's called the bundle of His, which splits into two branches, and those branches split into sub-branches and eventually end in Purkinje fibers. These are not really visible in the heart. All of these fibers basically look like ordinary heart cells, but they simply have a greater potential for moving electrical current through the heart than the rest of the heart. So when these might be blocked, or when the electrical current flows through different parts of the heart in an uncoordinated fashion, then essentially what we do is we get discoordinated pumping of the heart and an exacerbation of the heart failure. It's very important to realize that the EKG that we see is not actually showing us the contractions of the heart, but rather the contraction of the atria follows the traveling of the electrical current between the SA node and the AV node. And then the contraction of the ventricles, which we see on the EKG, is what we call the QRS complex, actually follows a few milliseconds after we see that electrical output with the contraction. So this is just explaining that with the EKG. Trish, you can move through this little slideshow pretty quickly, so as we see the P wave, immediately after the P wave is the atrial contraction. The electrical current flows through the bundle of His, the anterior and posterior bundle branches into the Purkinje fibers and causes this QRS complex. Immediately after the QRS complex is the ventricular contraction. And then we see this final waveform, which is a very interesting waveform, which is called the T wave, which is essentially the repolarization, the the cardiac muscle fibers, which have just fired off in unison, are now resetting themselves, and we see that as a kind of rounded wave. And that when we see that rounded T wave, we know that the ventricles are then just after that are going to relax again and be ready for the next beat. Let's keep going.
Okay, so we have another quiz. Match the wave components of the electrocardiogram to indicate which parts of the cardiac cycle they represent. Okay, so I don't know if we have, do we have a poll for this too, Jen, or no?
We do not. Only the multiple choice questions.
Okay, all right, then we'll just go through it here. So the electrical signal of depolarization that results in atrial muscle contraction is, I think this is right. Correct me if I'm wrong here, the P wave. The signal being sent across the ventricles, which is quickly followed by ventricular contraction, is the QRS complex.
Are you sure about that, Trish?
Okay, no?
No, you were right. You were right. That's okay. I was just trying to mock you. Well, I'm not going to give you any time.
Ventricle. I was listening. Is the T wave. All right.
All right, that's fantastic. Okay, great. So we're going to move on to cardiac output, and this is really the key take-home message in terms of heart failure. Heart failure is a lack of cardiac output. The cardiac output is not sufficient to the demands of the body. Those demands obviously change at rest, with exercise. They change with age, and they change with what we want the body to be able to do. And the key problem and therefore the key medications that we use are aimed at optimizing the cardiac output and getting, let's say, a sick heart, a non-perfect heart. The muscle's not quite as strong as it really should be, or it's not quite contracting in a way that's 100% coordinated. The valves might be faulty. All of these are reasons for heart failure. The blood pressure might be too high, so we've got to pump against a high-pressure system. All of those things are critical, and the heart rate is one of the main things that helps us control the cardiac output. Obviously, when the heart rate's higher, the cardiac output's going to get higher. That's controlled by a number of neuronal and hormonal regulators. Adrenaline we know about, as well as the sympathetic and parasympathetic nervous system, are very, very important in controlling heart rate. The other thing that we talk about is stroke volume, which cardiologists like to talk about ejection fractions from the left ventricle, but stroke volume is essentially the volume of blood that's getting out into the systemic circulation every single beat, and that's dependent. Actually, the heart is very interesting. The more we stretch it, the harder it pumps. So it's dependent on the stretch, which is dependent on how well the ventricles are filling, which is something we call preload. It's also dependent on the contractility of the muscle fibers, which is determined by both by their stretch. They can contract sometimes harder and sometimes not quite so hard. This is just explaining how preload is determined by the venous return to the right atrium, and that we have pumps. So people that are very immobile can't necessarily make full use of their venous return pumps. The diaphragm is another major venous return pump. As we breathe in and out, we change pressures, which encourage the venous blood to come back. Obviously, the contractility or the strength of the contraction is very, very important. And if we lose heart muscle through a heart attack or whatever, then we lose strength of contraction, which is fairly intuitive. And obviously, the final thing, and this is the thing that we often deal with, is afterload, which is essentially the pressure against which the heart needs to push, essentially the blood pressure. So the way in which we decrease the afterload and sometimes even the preload is via diuretics. We take water out of the system. We don't want to stress the heart out too much, so we can decrease the heart rate using beta blockers, which influence the parasympathetic nervous system. We also use some of the key medications like ACE inhibitors and angiotensin receptor blockers, which decrease blood pressure and also have an effect on fluid retention. They decrease fluid retention. And finally, we want to make sure that fluid retention is not too bad. Okay.
And this we're just going to go through kind of quickly. The blood vessels. Yeah. I think everyone is very familiar with this. I'm just trying to be conscious of time here.
Yeah, thanks for that, Trish.
Sorry about that. I know we had a lot of questions earlier, so I'm just going to kind of go through this really quickly. I think it's is it this one? Oh, got it wrong. Okay, structures of the veins. We're just going to go through because we kind of went through this already.
I agree. We don't need to. I mean, that's less important.
Yep. These are continuous capillaries, just so that we know what they look like. These are fenestrated, and these are sinuous. Okay, the major arteries.
Okay, so it's important just to remember that also when we test blood pressure, it depends which artery we're testing it for. Blood pressure should be different in the carotid artery, in the brachial artery, and even in the femoral artery. The major artery is obviously the aorta, which carries blood away from the heart. It gives blood to the arms via and up into the head via the carotid arteries, and then it goes essentially the aorta goes down into the abdomen, where it gives off its branches to the bowel, the superior mesenteric, the inferior mesenteric, and the celiac artery, and then the superior and inferior mesenteric arteries. And then it splits into the common iliac arteries, which give their branches to the lower pelvic organs, and then follow off into the femoral arteries, into the legs. We can keep going. It's just a refresher of the structure.
We have another pop quiz. What are the arteries that specifically supply blood to the organs? And John just mentioned it's the mesenteric arteries.
Yeah. Well, the abdominal organs in any case. And then we have obviously the major veins, including the coronary sinus, which drains the heart itself. Superior vena cava, draining everything kind of above the heart, including from the arms and head and neck, and the inferior vena cava, which is draining everything below the heart. And they all empty into the right atrium. We also have the veins that bring blood back from the lungs, the pulmonary veins, and empty into the right atrium. Into the left atrium. As we said, the capillary beds are, and this is what gives us this incredibly long length of vasculature, which is, gets us a quarter of the way to the moon. In these capillaries are so small that usually they can only let one red blood cell pass at a time, or one blood cell pass at a time, and everything slows down here and enables nutrients and oxygen and carbon dioxide to diffuse into the cells which are surrounding there. Yeah, I think we might just skip through the hemodynamic, because it's a little bit complex. Is that okay?
Yep.
And we'll just because I just want to say a couple of words on blood pressure regulation before we finish up.
Okay.
Excellent. Getting better at this. Yeah. So blood pressure is a function of the cardiac output and the systemic vascular resistance, as we said. So when the arteries and specifically arterioles are contracted, then that'll increase blood pressure, and when the heart's pumping harder, that'll increase blood pressure as well. And there are a number of very, very, very complicated mechanisms. Now, as we said, if the heart has to pump against a high blood pressure, then that's going to cause it to come under strain, and a heart that's already injured, that can cause then an exacerbation of heart failure. So we'll just go through one of the important mechanisms. Can move forward a little bit. The pulse, obviously, when the blood pressure changes between what we call systole and diastole, which is when the left ventricle contracts, the blood pressure goes up. That's the 120, the 120 on 80 millimeters of mercury. And then when the ventricle relaxes, we still maintain a strong pressure in the arteries, which is the 80, which is the diastolic blood pressure. As I said, blood pressure regulation is a whole science in itself. There are specialists just in blood pressure. It has to do with higher brain centers. It has to do with the medulla oblongata. We have baroreceptors and chemoreceptors in our carotid bodies and in the aortic arch. And all of these are act together in order to determine what our overall blood pressure is going to be, and to maintain our homeostasis, to maintain optimal blood pressure for what we need, which is nutrients getting to the thing. Let's hit the slideshow, which I think talks about the renin-angiotensin-aldosterone system, which is really important because some of our most important drugs in blood pressure deal with the some of our most important blood pressure and heart failure drugs deal with the renin-angiotensin-aldosterone system. And then I know we're going a little over time, so then I'll just finish up. Oh, sorry, we missed that. Should we just finish up to be on time?
Yep,
In any case,
sorry,
you can go through the RAS. No problem. You can go through the RAS system yourself, and if you have any questions, you can always feel free to contact us, and I'll be more than happy to answer questions later on. In the online module, you'll be able to have a look at the summary, which really goes through all the key points of this module. And I think the key take-home message here is, heart failure is something that we can understand, something that has a very, very profound anatomical and physiological basis. When we understand that, beyond understanding all the patient factors and social factors and healthcare system factors which cause readmissions, just understanding the basics of what's actually going on in the heart and the blood vessels, we're going to be able to really understand how we can prevent those readmissions at the very source, which at the end of the day is the physical body of each and every patient.
And just in summary, as John mentioned, some of the ways that we can decrease cardiac readmissions, we also have some white papers and some articles available for those of you who would like to take a more in-depth view. We also have a list of the hospitals throughout the country that have the highest and lowest rate of cardiac readmissions, and I'm happy to share that with you as well. But in conclusion, we'd like to thank you so much for your time this afternoon. And again, we can be reached at www.A.D.A.M.com. And we appreciate your time today. And what we'll be doing is including a link on the site here in the chat that you can link into the final assessment in order to receive your 1 contact hour credits. We'll also include a link to the program that you just saw today, Introduction to the Cardiovascular System, so you can also view it at your leisure. But again, we wanted to thank you so much for your time today, and good luck.